Good morning, everyone. On behalf of all the speakers, I would like to welcome all of you to our instruction course, which is Refractive Surgery Toolbox and what all do we need to become successful refractive surgeons. So as we all know that refractive surgery is such a dynamic field, and there have been many advancements in the technology in the recent years that have improved the outcomes of refractive surgery in terms of patient satisfaction and surgeons' confidence in decision making. So I have a wonderful panel of speakers here, which is a nice mix of experienced and seasoned refractive surgeons such as Dr. Shri Ganesh, Dr. Sheetal, and we have a bunch of very enthusiastic young ophthalmologists also with us, Dr. Supriya, Shri Ganesh, Dr. Karthik, Dr. Raghavendra, who have recently started on with their refractive surgery career. And we would also love to hear from them. What do they think about the new technologies and how they use these technologies in their clinics for their and their patients' benefits? So I think can we start with the talks? Okay. So I would request all the speakers to stick to their time so we have enough time for discussion towards the end of the session. So I would like to invite our first speaker. It's my great pleasure to invite my beautiful namemate and a wonderful friend, Dr. Sheetal Mahuvakar. She is a well-known cornea, cataract and refractive surgeon from Retina Foundation, Ahmedabad. And she'll be giving her talk on topography, what works and what doesn't work in the modern day refractive era. So Dr. Sheetal, all yours.
Yes. Thank you so much. And a very good morning to everyone. At the outset, I want to thank my dear friend Sheetal for including me in her wonderful IC. That's okay, yeah, okay. So today I'm going to talk about topography, what works and what doesn't in modern day LASIK practice. So I will start my talk with a patient which I saw a few days back in my OPD. A 38-year-old gentleman walked in with decreased vision. He gave me history of LASIK done 7 to 8 years back for a very minimal refraction, as you can see it on the board. What he showed me was his pre-op Pachy of 500 micron, and a K-metry topo was written, but there were no images like 45 and 43. So to be very frank, when you see it, it doesn't look very, very abnormal. His current refraction in the right eye is -1 cylinder with 6/9 vision, and left eye was plano with 6/6. When we did his topography, there was a frank post-LASIK ectasia in the right eye. And if you see in the left eye also, there is a ectasia which is developing. So this brings us to a very good important that why is it so important for us to do a very good pre-LASIK or pre-refractive surgery evaluation. Even though the incidence of post-LASIK ectasia, there's no precise incidence available, but it is still there, and we do not want our young patients to get into this lifelong problem in their life, you know. So it's very important for us to do a very good evaluation and see whether a patient on which we are going to do a surgery is safe to undergo these kind of operations. So what are the common risk factors for post-LASIK ectasia? As we all know that low residual stromal bed thickness, abnormal preoperative topography, thin corneas or high refractive index, so the more ablation is there. So it's very important, as I mentioned, to do everything, whatever is there in our clinic available, or if it is not there, maybe you can go to take whatever, like, you know, other your friends clinics help and do the evaluation properly. So we do require a stable refraction for 1 year, normal topography, pachymetry more than 500 or RSB of 300, epithelial thickness maps, specular microscopy, aborometry, and all of these are going to be discussed by different consultants out here. What I am going to talk about is topography. This brings us to a very important question: what is topography and what is tomography? So topography is basically, it's like a 2D, 3D kind of a thing. Topography uses Placido disc principle, so it only evaluates your anterior corneal surface and the tear film. And tomography is a 3D kind of computation, so it actually gives you or assess anterior and posterior corneal curvature, something in between these two. It gives you corneal thickness, anterior chamber depth, and it also gives you information about iris and lens. So there are different technologies by which this can happen, like a scanning slit technology, a shim-flug imaging, and OCT also. What I am going to discuss here is pentacam and series. So pentacam uses shim-flug imaging, and Cirrus and Galilei are the ones which use Placido disc as well as the Scheimpflug imaging. So why tomography again? As in my first example, what I showed is everything looked normal. Maybe the topography was done, but everything was maybe normal in that we did not have images to comment on that. But sometimes the epithelial changes around the cone, they tend to mask the early ectatic changes. So it is very important for us to evaluate the posterior surface, because you can pick up a lot of subtle changes, as keratoconus many a times manifests with posterior changes. So instead of topography, what we are going to discuss is tomography, and instead of just pre-LASIK surgery, what we are going to talk is, whenever I say pre-LASIK, I'm talking about everything pre-LASIK, pre-SMILE, pre-PRKs, and all the refractive surgeries which are there in our armamentarium. So this is a very typical refractive map of pentacam. As you can see, it gives the sagittal curvature, anterior, posterior elevation, and corneal thickness, the global pachymetry. So our antennae, or the red flags of these are, whenever there is any kind of inferior irregular steepening, like this, anterior elevation more than 12 microns, posterior elevation more than 17 microns, and all these things should match with the thinnest point. So all the things should coincide with each other. It cannot be that your steepening is somewhere else, your cone is somewhere else, the posterior elevation is somewhere else, and the thinnest point is somewhere else. That doesn't work. So you have to coincide all these things, and then it actually gives you the diagnosis. The tomography, the elevation, what we are talking about, brings us to the concept of reference surface. So what it is basically is, you need something to compare with, or you need to kind of unmask the irregularities in the cornea. So you need a reference surface which matches your cornea a bit, and then it will kind of enhance your subtle irregularities. So there are different reference surfaces which are available, like pentacam uses spherical best fit sphere, Cirrus uses toric sphere. There would be you have a choice in each machine that you can go and actually change it, and every time you have like every machine will have a reference surface for that particular cornea. This again brings us to the concept of enhanced reference surface. So what is it actually? So the reference surface, as I said, is for each cornea. Like if I do topography, for me, my reference surface machine will measure, and that reference surface is utilized, and whatever is up above that is elevation, whatever is there is below that is flatter cornea. So enhanced reference surface, how pentacam does it, it is generally taken the whole cornea, but in enhanced reference surface, what it excludes is a 4 millimeter area around the thinnest point. So the steepest point, if there is a keratoconus, the steepest points are there around your thinnest point of the cornea, they are excluded. So the resultant enhanced surface is flatter in keratoconus. What happens in a normal cornea is your enhanced reference surface as well as the normal reference surface will be more or less same, because there are no steep points or no abnormally steep points. But in keratoconus, around that thin point, there will be lot of steep points which are excluded. So it kind of accentuates your subtle cones with the enhanced reference surface. And this is the concept they have used in the bad display. The first two are the normal reference surface, the middle row is with the enhanced reference surface, and the lower row is what the difference between the two, and they make a category into green, yellow, and red. Again, on the right hand side, there is a pachymetry section which is very important. CTSP and PTI is nothing but basically what they mean is how a pachymetry or the thickness is changing from your thinnest point towards the periphery. So it gives you subtle clue about whether there is an edema, whether there is thinness, how your pack is changing from thinnest point towards the periphery. These red marks are not parameters, but it's just a regressive analysis. So you should not worry if there's one single red mark which is there. You should always correlate all the things together. There are a lot of asymmetric indices. Generally, the vertical asymmetry indices is important. This is a Cirrus map. The colors look very different, but you actually start reading it, it's very, very similar to pentacam. These are the same 4 maps. Instead of the sagittal anterior curvature, it uses by default tangential anterior curvature in Cirrus, and there are the same 4 maps which are there. What Cirrus has, how it kind of evaluates keratoconus is by the symmetry index, vertical asymmetry. It considers the highest point of ectasia on anterior posterior elevation, and it kind of presumes that the cone starts in the inferotemporal area. So BCVF and BCVB is nothing but it manifests the coma, trefoil, and the spherical aberration. So it considers all these things findings along with your minimum thickness and classes your topography into normal, abnormal, suspect, or frank keratoconus. Keratoconus summary is a very nice map. The middle row, what you are seeing is it's the patient's elevation, which is compared with the standardized elevation, the normalized standard, they have it in the machine. The right hand side corner is very good. I really like that map, the black and white one, because it kind of gives you all the points. If they are together, that means everything is coincide. But if those points are scattered together, it's probably not keratoconus and something else, or it could be just a normal cornea. It also gives you the Cirrus also gives you the CTSP and PTI chart. So the machines are more or less same. You just need to get used to all these machines. So this brings us to one more example. So if you see this particular pentacam map, the curvature map looks pretty okay to me. Elevation anterior is good. So if this was only a topography, maybe we would have gone ahead with the LASIK surgery or any refractive surgery. But if you see the elevation, there is a minor small elevation. It's plus 16, not big, but it should kind of put your antenna up that, okay, this could be something abnormal and you should avoid surgery in such cases. Again, this looks very, very normal to me, but if you actually see, the thinnest point is way away from your central point, the apical point. So these are the subtle signs which the tomography gives us. Maybe this is a very, very early sign and you should watch such patients and not go ahead with the refractive surgery. So tomography that way gives us a lot of information which is happening throughout our posterior cornea and the pachymetry. So these are again the patients where your anterior curvature seems perfectly normal, but both his eyes had on posterior elevation, there was a cone as well as a thin pachy and decentered thinnest pachy. This is a Cirrus map again. It looks different, but if you start reading it, it's the same as I told you earlier. There is an inferior steepening out here, not much, but it is there. So these are again very thing for the refractive surgery. So these are the cases which are very, very important for us. Even though the machine shows suspect, I would say not even do PRK in such a case. So you should follow up such patients, take history. This is a very, very interesting topo. When I saw this topo, there is an inferior asymmetry. Anterior posterior elevation is fine, and if you look at the pachymetry, it's very, very thick cornea. I do not know what it is. Then when I saw this CTSP, PTI, the first thing which came into my mind is we should do specular microscopy, because this could be a case of Fuchs, the way it is progressing, the CTSP, PTI. So these are the clues you get it on tomography, and maybe again Fuchs is it's a contraindication for your refractive surgery. Although the pachy is very, very good in such a case, maybe this case is again also a no for refractive surgery. So to summarize it, tomography is must for new age pre-refractive surgery evaluation, because we need to be very, very safe in this era for our patients. Curvature map, elevation map, thinnest point, all should be considered together, and do not read only one particular map. Posterior elevation and global pachy will give you a lot of subtle changes and early signs for you to look into the topography. And BAD-D, because it uses enhanced reference surface, kind of enhances subtle cone. Thank you so much.
Thank you, Dr. Sheetal, for that very detailed talk on pentacam. It was almost like a mini masterclass on topography. Very well explained with nice examples. So I just had a small question. How reliable do you think is the BAD display? You showed some really good examples of BAD detecting early keratoconus, but do you always depend on BAD, or do you have some other parameters?
No, so as I said, I generally do not go only by one particular thing. Maybe my BAD is bad, but then my 4 maps are pretty decent, you know, and the examination is okay. So I may not just kind of refuse the surgery for that patient, but I will not even go ahead directly, and I would watch that patient maybe after 6 months again repeat the tomography.
Because BAD, so few times I have seen if the cornea is just steep. Yes. Just a steep cornea, if it's a contact lens wearer, you will see changes on the difference map in the anterior.
Exactly.
So it's just for the audience that do not believe these maps with closed eyes, and don't trust them blindly, because you have to correlate everything clinically and then decide on the
all the maps and all the indices which are available, you have to always study them together and not only single BAD-D. Okay, BAD-D is bad, so you should not do that. You should always kind of take everything into consideration. If there is a doubt, repeat the tomography after 3 months or 6 months and then decide.
Wonderful. Thank you so much.
Thank you.
So we will have more discussion towards the end of the session. So it's my great pleasure to introduce our next speaker, Dr. Raghavendra Reddy Arra. He was a fellow with us in Netradhama. He's done his long-term corneal cataract refractive fellowship with us from 2017 to 19, I think. Yes. Right? So he was very active in research and also won awards at Karnataka Ophthalmic Society, I think the best video award and the best paper award. So Dr. Raghavendra currently is a consultant at Win Vision Eye Hospitals, Hyderabad, and today he'll be speaking on corneal biomechanics. Let's make sense out of it. Over to you, Dr. Raghavendra.
Good morning, everyone. Today I'll be talking about corneal biomechanics. So corneal biomechanics is basically the study of cornea to an external force, and cornea by its nature exhibits properties of both viscosity and elasticity, and all viscoelastic materials demonstrate a property called as hysteresis, which is basically a differential response during a loading and unloading response. In terms of corneal hysteresis, it is the ability of cornea to absorb and dissipate energy, and it is basically a dynamic behavior of cornea. So does corneal mechanics make any difference? Especially when you're looking at eyes which have a risk of ectasia, these eyes usually go through various phases before landing up in an ectatic phase. Basically, there is a change in the biomechanical properties, then there is biomechanical weakening, followed by tomographic and topographic changes. Finally, you manifest all these signs on a slit lamp. So it's very important to identify these eyes which are at risk of ectasia at its earliest point. So the current standard of care with most of the surgeons is they look at the corneal topography or tomography map and then the aberrations. Based on this, we usually decide the surgical procedure. But there are very few subset of corneas which usually land up in ectasias because of biomechanical weakening. It is very important to identify these corneas which might land up in ectasia. So by including corneal biomechanics in the routine evaluation process, you can identify those biomechanically weak corneas and then select an appropriate procedure which would result in uneventful surgeries. So there are various ways by which you can measure corneal biomechanics. The ones which are usually feasible are the in vivo methods such as the ocular response analyzer using Corvis and the Brilon optical microscopy. So there are few biomechanical properties that have been demonstrated with ex vivo technique. That is, there is a non-linear stress versus strain response. That is, at a lower strain, it has a non-linear relationship, and at a higher strain, it is more of a linear relationship. And the cornea, that is especially the peripheral and the mid-peripheral cornea are is slightly stiffer than the central cornea. The cornea, it stiffens with age, and the anterior 40% of the cornea is more stronger than the posterior 60%. Ocular response analyzer, this was the first instrument that was introduced that could measure the corneal hysteresis. Basically, it contains a air puff tonometer which causes a corneal deformation. This deformation is picked up by the infrared emitter, and then it is depicted in the form of a graph. There are various measurements which you can get with ORA, that is the Goldman's applanation IOP, Goldman's correlation IOP, the corneal compensated IOP, the central corneal thickness, corneal hysteresis, and the corneal resistance factor. But there are few limitations with this, with the ORA, that is there are discrepancies from the expected results. The ORA waveform analysis alone does not suffice. And CRF, that is the corneal resistance factor, is dependent on corneal thickness rather than the corneal stiffness. Another way of studying the viscoelastic properties is by Brillouin optical microscopy, which is basically, it depends on the Brillouin scatter. So whenever there is an interaction of incident light with acoustic phonons, which are nothing but atoms in vibration, there is a shift in frequency. This shift in frequency can be measured by a spectrometer, and then the shift in frequency is then converted into an elastic modulus, which gives us the elasticity of the cornea. So this is image taken from a Brillouin optical microscope, and the various layers, and how these are how the viscoelastic properties of each layer is. Coming to Corvis, this is the latest and most reliable and consistent way of studying the corneal biomechanics. It consists of an air puff tonometer, which usually projects an air puff onto the cornea, and this air puff usually causes a corneal deformation, resulting in an ingoing phase. Then you have a highest concavity phase, undulating phase, and then the outgoing phase. In the Corvis, you get a display called as a DCR display. It's a dynamic corneal display. On the left hand side, you have the various parameters such as the amount of deformation, the highest concavity, the first and second applanation which the cornea undergoes during this bidirectional applanation process, and these are mapped against time. And the softer corneas usually have a higher deformation amplitude ratio. The indicated radius is higher, and the ARTH and the stiffness parameter at first applanation is usually lower, and for the stiffer corneas it is vice versa. So the corneal deformation response, this is a corneal deformation response in a normal cornea. You see the ingoing phase and then highest concavity. This is followed by an outgoing phase. This is a comparative video of a keratoconic eye with a normal eye, where you can see the deformation is more, the applanation length is less, and there is more of undulations at its highest concavity. And similarly, in a keratoglobus, you can see the amount of deformation that a cornea undergoes. Corvis can also be used to compare the pre and post C3R effect on the cornea. In the post C3R corneas, you can see that the deformation is almost the same, but the undulations and the stability of cornea is slightly better. Vincingvera report is a screening report which is similar to the bad display of Pentacam. Here you can see the various parameters such as the deflection amplitude and the deformation amplitude plotted against time. One important parameter which the Vincingvera screening report gives is the stress strain index. It basically tells us the stiffness of the cornea. The corneas which are having SSI less than 1 are usually stiffer, and towards the right the softer corneas. Corvis biomechanical index, this is another parameter given in the Vincingvera screening report. It is basically a linear regression analysis of the 4 parameters that is taken, that is the deformation amplitude ratio, integrated radius, ARTH, and the stiffness parameter. Here the zone in the white is the one which is there in the 2 sides of the standard deviation, which is within the normal limits. The other display is the ARB display, also called as the biomechanical display. Basically, it combines the data taken from the Corvis with that of the Pentacam to give us a value, that is the tomographic biomechanical index. So CBI and TBI more than 0.3 is considered to be suspicious, and more than 0.5 is abnormal. So there is a entity called as the CBI LVC, that is the machine automatically detects eyes which have undergone surgery, and CBI post LVC is a value which helps us in assessing the biomechanical stability post operatively, and it also estimates the risk of ectasia. So this is one case scenario, a patient who has come for a refractive surgery opinion, and this is the subjective refraction. If you look at the 4-map refractive display, all the parameters are within normal limits, and also the bad display which is within normal. When you look at the Vincingvera screening report, the CBI is around 0.04, which is again within normal. SSI is less than 1. So the ARB report, it also shows the TBI is almost close to 0, which is again within normal limits. And for this patient, a routine smile was planned with the residual stromal bed thickness, which is more than 300. This is an interesting scenario where you can see the subjective refraction was around -3 and -2.5. The 4-map refractive looks normal, but the corneal thickness is slightly at the borderline. And the 4-map refractive is also, the bad display is also normal, but when we look at the Vincingura screening report, the CBI is almost 0.75, which indicates the cornea is slightly biomechanically weak, and also the SSI, which is usually more than 1. And the ARV report here also, it's basically the TBI is little suspicious. And in this patient, we have done a smile extra procedure, even though the residual stromal bed is more than 300. This is mainly because of the biomechanically weak cornea. There's a new display which has come with Corvis, that is the comparison display. Here basically you can take measurements at 2 different points and compare this Corvis biomechanical properties. That is, the blue is at one time point and the red one is the other time point. And you also have a video which you can compare the deformation response. And these are the various parameters that are plotted between 2 measurements. And you can also see that the SSI, here you can see whether the cornea has become stiffer or it is the same or it has become soft. So this has been improvised as the best display. This mainly helps in monitoring the biomechanical stability over time. You can basically measure the stability of corneas after laser vision correction or else after doing C3R. And you also have a keratoconus staging in this display. So apart from the Vincingura screening report, which can be only used for screening and for pre-laser vision correction, this can be used for post-LVC eyes also. To conclude, Corvis helps in screening patients for refractive surgery and also helps in selecting the appropriate procedure. You can monitor the biomechanical stability of the cornea after laser vision correction and identify those eyes which can land up in post-LASIK ectasia at its inception. And you can monitor the progression and also verify the success of C3R in keratoconic eyes. And it also helps in screening patients for glaucoma. Thank you.
Thank you, Dr. Raghavendra, for that very elaborate talk on Corvis and showing all those nice examples where tomography looks completely normal, topography is normal, and I think the main utility of Corvis is identifying those corneas which look topographically normal, but the intrinsic factor of biomechanical strength is something that we can only study by a Corvis or any other biomechanical measurement device such as the Brouillon microscopy. So thank you for explaining all these concepts in such a simplified way. So I think the next speaker is myself.
It's my pleasure to introduce the next speaker, Dr. Sheetal Brar. She's conducting this IC and the chief instructor. She will be just a short introduction. She did her cornea fellowship from Arvind, and then she did a phaco-refractive fellowship from Netradama, and she has numerous awards to her name. Every film festival she has won, and she has some very nice films and a lot of best papers and over 50 publications. And she will be telling us the story of the epithelium and how important it is. And this is something that a lot of us do not look at. But it is increasingly being talked about for refractive surgery screening now. Over to you, Dr. Sheetal.
Thank you so much, sir, for the kind introduction. So good morning, everyone. I'll be talking about epithelial thickness profile and how it can be so useful to us as refractive surgeons. So I'll start with some facts about epithelium. We all know that epithelium is a barrier to the external environment. However, along with the tear film, it also has a very important function as it represents an optical interface that plays a critical role in the refractive power of the eye. So even small changes in the corneal epithelial thickness can cause significant refractive changes. The power of the refractive epithelium alone ranges from 0.5 to up to 1.85 diopters in the central 2 mm diameter zone. So this is very significant for a refractive surgeon. So various studies have evaluated epithelial thickness profile, and this was a paper from Reinstein et al., and they have demonstrated that the epithelial thickness profile is actually non-uniform. So it's not uniform in all the zones of the cornea. So the average central epithelial thickness is 54 microns with a standard deviation of 4 to 5 microns. The superior epithelium is slightly thinner compared to the inferior, and the temporal is slightly thinner compared to the nasal. So superior is thinner because of the blinking action of the lids, and temporal because of the more exposure to the temporal quadrant of the cornea compared to the nasal. So as a refractive surgeon, we must be very cautious because, as I already said, that epithelium is not a homogeneous layer over the Bowman's membrane. So if you can see here, this is an advanced ectasia, and over time how epithelium is covering this ectasia, this surface. So if you do a topography, it would actually look like a normal. In this area, it will not probably show very ectatic cornea because epithelium is filling this gap so nicely. So it compensates for stromal surface irregularities. It becomes thicker over valleys and thinner over the hills where the stroma protrudes, as it attempts to minimize abrupt changes in the stromal thickness. So the anterior cornea may appear smoother on topography compared to underlying stroma, and if you only assess your topography without any knowledge of epithelium, it may be misleading. So in the current scenario, we have ASOCTs and very high frequency ultrasound such as ARC scan to measure epithelial thickness profiles. Principle of ASOCT, we all know, it's spectral domain OCT, and the ARC scan has a 50 to 100 megahertz ultrasound system. OCT is a non-invasive, non-contact method, whereas with the ARC scan, it's an immersion method and needs a special medium and topical anesthetic. OCT is less operator dependence, and ARC scan has a high operator dependence, due to which the repeatability and accuracy can suffer sometimes because of corneal compression or decentered position of the probe. And in the OCT, the tear film is included, whereas in the ARC scan, it is not included. So out of all the commercially available OCTs which are there for epithelial thickness measurement, the MS39 is the recent one. It does not require a cornea external lens. Its resolution also is the highest, and the area measured is also the widest. It's 16 millimeters compared to the others. So let's look at the clinical applications of epithelial thickness mapping. So first and foremost, it's the screening of ectasia risk factor, ectasia risk in refractive candidates. So as we know that corneal thinning is a hallmark of corneal ectatic diseases, and in histological studies it has been shown that there would be a localized zone of epithelial thinning over a steep area surrounded by an annulus of thickened epithelium, classically referred to as epithelial donut pattern. So if you see, this is a moderately advanced case of keratoconus. That's the cone, and this is the epithelial thickness profile. So corresponding to the cone, there is a thin area on the top, basically here, and this is around the cone. You have a thickening of the epithelium in the form of a donut. So this is a typical donut pattern that is seen in ectatic diseases. And here you see a case which is a suspect on topography. Basically, this is a pentacam map of this patient. So there's a little bit of inferior asymmetry. And here there is elevation of about 29. Of course, a high elevation of 29 is highly suspicious of keratoconus. You can use epithelial thickness for verifying this as well. So when we do MS39, you can actually see, because this is a OCT that along with the tomography also gives epithelial thickness. You can see corresponding to the area of elevation, there is epithelial thinning here, and around this there is some amount of thickening of the epithelium. So early donut pattern is forming in this case. So epithelial thickness profile can also be used to enhance the specificity and avoid false positive cases. So sometimes on topography it may look like a keratoconus suspect, but if you confirm with epithelial thickness profile, it actually may not be the case. So say in this case, you can see that it's a regular with the rule astigmatism, and it's a slightly thin cornea, 460 microns. The posterior elevation is plus 15, anterior elevation is normal. So here if you see the epithelial thickness profile, it's absolutely normal. In the center there is in fact epithelial thickening and not thinning. So it's a normal epithelial profile. So probably you can observe this patient, or if the patient's refractive error is low, probably you can do a PRK or an extra procedure also. So in dry eye, the epithelial thickness profile is something like this. Overall epithelium becomes thinner, and this is something which is a sensitive parameter for refractive candidates. So planning refractive procedures. Specifically for those procedures where epithelium is involved, such as trans-PRK and phototherapeutic keratectomy or the PTK, it's important to have a knowledge of epithelial thickness profile. As we know that there is a variability and there is a differential distribution of epithelial thickness on the cornea, so the nomograms have to consider these observations. So refractive regression, again, very, very important topic for refractive surgeons. We all know myopic corrections can over time show regression over time, and this is because of the epithelium compensating the flattening in the center. So we published this paper in 2016, which was aimed at evaluating epithelial thickness profile following SMILE for myopia and myopic astigmatism. And what we found was that in low myopia, there was a thickening of about 6.8% at the end of 3 months, in moderate myopia 9.2%, in high myopia as high as 12.7%. So this is so significant, and through this you can actually also differentiate between regression and undercorrection seen in the post-op period. So your treatment plan or how you're going to manage the patient is completely going to be different once you are sure of your diagnosis. Early ectasia versus regression. This is again, of course, an advanced ectasia does not need a epithelial thickness profile to diagnose it. However, there can be cases where the ectasia is really early, and there it can actually help you a lot. So this is a case operated for -9 diopter SMILE, and at 6 months patient was accepting a -1 with 0.75. And on the right side I have a case that was operated for almost 5 diopters, 5.5 diopters of spherical equivalent post SMILE at 3 years. Patient was accepting a similar kind of a refraction, 1 with 0.5. But if you look at the epithelial profile, it is completely different in both the cases. So the first one is actually showing regression due to epithelial thickening in the center, whereas on the right side you see an early donut shape pattern which is forming with a thinning in the apex and a thickening in the mid-periphery. It can also be used to differentiate between myopic and hyperopic ablations. Again, for classical cases, for higher corrections, it is not so important. However, sometimes we get patients for cataract surgery whose refractive surgery was done many, many years ago, refractive error was low, and the pachymetry and keratometry can actually appear to be very regular. So due to the epithelial hypertrophy that has occurred over time. So in those cases, when you do epithelial thickness profile, it can actually tell you about the type of ablation that was done. So for myopic cases, of course, you will have some amount of thickening in the center, and in hyperopic, it will be a pattern quite similar to keratoconus, central thinning with the peripheral, mid-peripheral thickening. So planning enhancements, again, very important, especially if you want to plan enhancement for SMILE and you want to do a thin flap LASIK. This is very important because if you're not considering epithelial thickness and you want to plan a flap over a cap, you might end up either too superficial or deeper. So it's very important to measure epithelial thickness and accordingly plan so that you do not enter into the epithelium and cause a buttonholing. And you should also have a sufficient clearance from the previous interface. So to conclude, knowledge of epithelial thickness profile is especially beneficial in close call clinical judgments. And the newer modalities combining epithelial profile with stromal elevation maps enable a more confident decision making by ruling out false positive cases of suspect keratoconus before refractive surgery, and are thus very helpful to a refractive surgeon. Thank you so much for your kind attention.
Wonderful talk. And I think this is what I meant, that epithelial thickness map, sometimes the topography will show normal and epithelial thickness. Because of the epithelial thickness, it is actually unmasked your subtle cones, and epithelial thickness map can help in such a thing, or your tomography can help.
Thank you. Yes, sure.
Is epithelial thickness constant? Or is it constantly changing over a period of 1 month?
See, it's after refractive surgery, or are you in normal?
No, in general.
In general, yes, it can change a little bit depending upon the basically the dryness of the cornea or ocular surface condition. But still, I think, and if you also wearing contact lenses, but it probably might not change too much. Okay, the variation may be just within 4 to 5 microns, so you have to rule out any predisposing condition why it is changing. And also, if you have a doubt, you can always repeat the scan after 3
I
months.
got this doubt because post PRK we know that there's a lot of crowding in the center and everything. So in the same way how our epithelium constantly changes over 27 days, that is skin epithelium, is the corneal epithelium is constantly changing, right?
Yeah,
So whether there is a variation in the thickness in the epithelium over a period or in a whole month. So whether that has any effect in your timing of testing post
So post
refractive
PRK,
surgery
if
also.
you want to study the epithelial changes, the best time would be at 3 months, 3 or 4 months.
okay.
That's when you expect the changes to
Constant.
complete.
No, I
Thank
think I
you.
got your question. What you are saying is whether if you do it on day 1 and day 15 of the month, it doesn't, because what happens, how epithelial renewal happens is your superficial cells keeps on going and the newer cells from the base
Yes,
come.
yes.
So whatever your thickness is, if you take it on 1st June or 15 June, it is going to be same for a normal person.
Okay, thank you.
For a normal person, it won't change much. Yeah.
Can I ask a question?
Yeah.
Generally, we were speaking about localized thinning of the epithelium or localized changes. Do you account for the standard deviation of the epithelium? Because it's been seen that in keratoconic patients, the standard deviation is much higher than in a normal.
Yes, in a keratoconus, the established case of keratoconus, the variation from the thinnest point to the thickest point on the epithelium can be as high as 30 microns. Yeah.
Do you account in those cases as another factor,
For what? For planning treatment?
as a risk factor?
Yeah, see, the MS39 gives you pattern deviation. So if you look at pattern deviation of epithelial maps, then it shows up. So pattern deviation considers the normative data.
As a corollary to the previous question, he said that is the epithelium stable over time? The question is that the machine that we are measuring, because just before your talk, Dr. Sharon mentioned that we use it with an ASOCT or an OptoView machine. And she said that the epithelium which is measured, you cannot be certain that it has been mapped every time the same way for you to really tell that it has been consistent or whether there has been a change from the 1st to the 3rd month. So what would you say about that? Is ASOCT a good tool? Because maybe MS39 is not something that everybody will have.
See, the regular ASOCT, again, it depends upon the resolution. If you have a resolution of 10 microns, then again, you can have more variation. MS39 has a resolution of about 3.8 microns, so the accuracy would be better. So it basically depends upon the resolution, it depends upon the imaging software. There are a lot of parameters. The time of the day when you are testing, because that again changes the corneal hydration and the epithelial hydration. If there is any eye rubbing, if the patient has worn contact lens, there are so many factors. But generally, in a normal person, the deviation is not more than 4 to 5 microns. So if your accuracy is less than 5 microns, then it makes sense. If your accuracy is 10 microns or 20 microns, then it's not going to pick up that.
True. So the ASOCT does have a 9 micron as
9
she
microns,
mentioned. So
yeah.
it would, you may have to take it with a pinch of salt.
Yeah, but it's in cases of like I said, regression
Yeah.
or healing or keratoconus, the difference can be high, like 30 microns when it's significant. The resolution is 10 microns, but if the difference is 30 microns, it will still
is
pick it up.
significant.
See, and most of the machines are like that, so that is the reason that you have to take slightly like at least 3 maps for every time to
conclude,
see whether
yeah.
you are getting a consistent result, and rather than just go for one map. So that is kind of pretty true for either your pentacam and Cirrus also.
Whether you are taking a 6mm zone or a 9mm zone, that is also important.
Yeah, of
This is about 13 microns, 13 millimeters with the ASOCT, yes, this is maximum. Because the other devices are about 6 microns or now 9 microns with the OptoView, which again, it doesn't go to the complete periphery. Suppose you have peripheral changes, suppose you have like a Tyrion's marginal degeneration, then it's not going to really look at it. I mean, it's going to reflect onto the center, and you may see some central changes, but it's not going to pick up those peripheral changes.
Also, hyperopic LASIK and also cannot pick up the changes. So we'll move on to the next talk. It's by Dr. Karthik Sri Prakash. He also completed his long-term cataract and refractive fellowship with us in 2019. He had won Best Paper Award in ACRS 2018, And today, and currently he's working as a consultant in Shri Eye Care, Eye Hospital in Bangalore. He'll be talking about role of optical quality assessment in refractive surgery. See how your patient sees. Over to you.
Thank you, ma'am. Always an honor and pleasure to be associated with my alma mater. Yes. We've all had this patient who's had an uneventful refractive surgery, and in the early post-operative period, the vision is 6/6, and the patient still complains that the vision is not good. This is a nightmare. We've all had this patient. So I'm going to be talking about a very important thing to see what exactly is happening. Optical quality is a very important and upcoming factor in refractive surgery since patients' expectations these days are sky high. Coming to optical quality, there are two main determinants which determine optical quality. The first is the aberrations, including the lower and higher order aberrations, including defocus. The second and most important thing is ocular scatter. So the main areas of scatter in post-refractive eyes can have anything to do with the interface, to do with the tear film dryness, or any kind of early media opacities as well. So what scatter does is that it increases the retinal stray light in the point spread function, and this causes significant deterioration on the quality of vision. So we need to objectively analyze the optical quality in these patients, and the analysis should take into consideration the effect of aberrations as well as the effect of scatter. Now, the HD analyzer does just this, and this has an advantage over traditional aborometry techniques, which tend to overestimate the potential visual acuity. So the HD analyzer works on the double pass system, where the first pass is a point source of image which is corrected by a Badal system for defocus and projected onto the retina. Now this retinal image is then transmitted and captured through an artificial pupil into a charge coupled device camera and analyzed. So this gives us the retinal point spread function image, and it is further analyzed by software to give us three parameters. The first is the objective scatter index, the second is the modulation transfer function, and the third is the Strel ratio. So what is OSI? The OSI is the objective scatter index, where it is an objective valuation of the intraocular scattered light. So it measures the amount of light outside the point spread function image and compares it to the light at the center of it. Now, thereby, the higher the value of the OSI, the worse is the visual quality. We take an OSI normally to be about 1.5. The second is the modulation transfer function. So this is basically comparing the contrast of any optical system, which is the eye in this case, and compare it to the contrast of a real scene. So this basically gives us the evaluation of a degree of detail that can be distinguished by any optical system. So the maximum MTF, since it's a ratio, is just 1. And as we know that the contrast reduces as the spatial frequency of the image increases. So at one point, the contrast becomes 0 or close to 0. And this is called as the MTF cutoff. So this is the highest spatial frequency which the eye can detect. So therefore, the higher the MTF cutoff, the better the optical quality is. The third parameter is the Strel ratio, which is the ratio between the peak intensity of the point spread function image of an abraded eye to the peak intensity of a non-abraded eye. So the higher the value indicates a better optical quality. Now coming to the steps of the optical quality assessment by the HD analyzer, the first and foremost is that the manifest diffraction has to be corrected and confirmed to at least the closest 0.12 diopters. Second thing is we always dilate the pupil. So this is because we can use the artificial pupil which is there in the machine to titrate at what pupillary value you would like to check the optical quality. So once we enter the demographic data into the machine, we also enter the manifest diffraction. Now the machine itself can correct a large range of spherical equivalents and a small cylinder up to 0.5 diopters. Anything more than that requires corrective lenses which the machine will suggest. The first sequence after entering the manifest diffraction is the best focus sequence, where it is necessary. We have to do this before we do any other optical sequence. Now this is necessary to avoid blurring of the double pass images, and the software searches for the best double pass image by sweeping for different spherical refractions to correct the focus. Now, the corresponding refraction is displayed along with the best display double pass image that the machine thinks is accurate. After this, we can proceed with the OSI measurement, where 6 double pass images with the best spherical correction is captured. Now, when we monitor these results, when we analyze the results, we see that on the right side bottom corner here, the OSI is displayed in a color-coded manner. Along with that, on the top side of, we have 2 images. The one on the left is basically the ideal image, and the one on the right is exactly what the patient sees. So this is basically the AV simulation which happens when this is the software does it. It basically convolutes the PSF with the original image of a scene. So this is a very good tool in explaining to patients and even understanding how the patient is seeing, so that even they can be counseled better, and even you can also understand how exactly or what the patient is feeling. Although this doesn't take into account the glare and halos, but it still gives us a good understanding of how the patient is seeing. It also displays the MTF after the analysis, which can be either linear or logarithmic, and we also get the MTF value and the trail ratio. The other advantage of this machine is that it analyzes the tear film so that we can check the degradation of the PSF image over time. So, and it also plots the visual quality index in such patients. So what happens is that you can differentiate whether the loss of quality is because of dryness or whether it's because of any other thing which is causing the scatter. Let's go to a couple of examples. So we're just going to be we're going to be doing a couple of cases. So we do this for all patients for us who come for follow-ups, all patients of refractive surgery. So this is a patient who had about a 4.5 diopter power pre-surgery, went in for SMILE. Surgery was uneventful, and on the first post-operative day, we see that the OSI is about 0.4, and in about post-op 1 month, the OSI is 0.3. So this patient, because the OSI is very less, so this patient has enjoyed very good vision from day 1 itself. Now compare this with case 2, who's a patient with PRK. When you see that the pre-op OSI, everything was absolutely uneventful surgery, on post-operative day 5, you see that the OSI is 3.2, the middle image there. And you see that the simulated image of the baby at 1 meter is so blur. But as the days go by, so at post-op day 15, the OSI has recovered, and at 1 year, the OSI is almost 0.2. Let's look at a third case of LASIK, where pre- and post-operative days, that is especially on post-operative day 5, the OSI is about 1. We'd like it to be less than that, but this is still okay. And at post-op day 30, it's about 0.5. So this capture can you can make the patient understand what to expect between different procedures, so that he can choose what procedure to undergo depending on the time that is taken for healing. And this is another important tool which you can explain. Another case that we saw, a little peculiar case, where we had a 35-year-old female who was planned for both eyes relax SMILE. The manifest refraction in both the eyes was about 1.75 diopters, which corrected to 20/16 preoperatively. Preoperative OSI reports are about 0.3 and 0.5. And on the post-operative day 1, surgery was completely uneventful, but the patient reported that the vision is still blurry. When we examined her, we found an unaided distance visual acuity of 20/20, which did not improve to more than that. And in the interface, we saw a very mild haze-like picture. So we subjected her to the anterior segment OCT, but it was inconclusive. So we did a HD analyzer for her, and as we see here, the OSI has significantly increased, almost at the yellow zone, so about 2.1 in the right eye and 2.4 in the left eye. So for this patient, we stepped up the topical steroids and asked her to review after 3 days. At the 4th post-operative day, she is improved. She's saying that the blurring is better, but still the OSI is about 1.5. So although so we asked her to continue the topical steroids and review after 1 month. Post 1 month, she's absolutely fine. She says that the vision is absolutely good. Both eyes, the vision is 20/16, what she was reading preoperatively. The interface looks absolutely clear, and the patient has been asked to review after 3 months. So to conclude, the optical quality analysis system is becoming more and more indispensable in modern day refractive surgery. The advantages of early detection of deteriorating optical quality and also the preoperative assessment of any kind of pre-existing scatter are invaluable in modern day refractive surgery. The advantage of the non-invasive dry eye assessment as well as the availability of temporal data, objective temporal data for follow-ups and monitoring is extremely important for today's practice. And I feel that it's a very important tool for patient counseling, especially to make them understand objectively, because it's so well represented that how they're supposed to see and how and what visual recovery they can expect. Yeah, thank you.
Thank you, Dr. Karthik, for that excellent talk. We'll have questions later. It's my great pleasure to invite the next speaker of the session, Dr. Supriya Samakshri Ganesh. She has recently joined as a consultant in Netradham Eye Hospital, a very skilled, able, and talented young ophthalmologist. Already has 2 ASCRS awards to her credit, 1 Best Paper and 1 Video Award. So a wonderful colleague also. So I would request her to start her presentation. Her talk is on aberrations and why do we need to care about them.
A very good morning. A very good morning to all my colleagues, my teachers, and friends. I'm Dr. Supriya, and today I'll be talking about aberrations. Why do we need to care about them? Thank you, Dr. Sheetal, for including me in your IC. So let's start with some of the basics of aberrations. So in wavefront aborometry, what is a wavefront? Basically, when any light passes through any optical system, it undergoes some changes as it comes out through that optical system. Some portions of the wave come out in front and some portions come out behind as plus or minus. Now all these points of light that are in the same phase, that surface is nothing but the wavefront. So here you see some numbers, plus 0.25, minus 0.4, etc. These are the objective values. So here what are aberrations? Now you see the blue lines. These blue lines are an ideal image point when in a perfect optical system, when light rays pass through that system and fall on a single point. Now you see the red lines. This is what happens in reality. The rays of light in the periphery converge more and the rays of light in the center converge less. So it forms multiple points, and these are actually what are aberrations or spherical aberrations. Now let's look at this map. The aberrations are quantified in the form of Zernike polynomials. You see the first 2 lines are the higher order aberrations, and below that you see the lower order aberrations. On the x-axis you have the radial order, and on the y-axis you have the angular meridional frequency. Now each aberration has a number. So here you see in the center we have defocus, we have coma, trefoil, etc. So the 3 most important aberrations that we look at are spherical aberrations, coma, and trefoil. We'll come back to this map later. Okay, so let's just talk about a few terminologies that we commonly use in aborometry. So the root mean square, these numbers that I talked about, when we square them, add them up and take the square root of these numbers, they give you a value which is measured in micron meters. It gives you an objective assessment of the total aberrations, and that's nothing but the root mean square. It's a quantitative analysis and not a qualitative analysis. Now point spread function, a point source of light, how does it fall on the retina? That's how these maps look. So let's take for example spherical aberrations. It looks like the point source of light is just spread out in circles. Coma looks like a comet shaped aberration, and trefoil looks like a Mercedes-Benz kind of symbol. Another parameter that we talk about in aborometry is the Q value, that is nothing but a number which tells us the shape of the cornea. So now coming to what gives rise to these aberrations. Any optical system which has imperfections, and they will give rise to aberrations, and in our eye they can either be anatomical because of the tear film, our cornea, our pupils, our lens, vitreous, etc., any of the media. It can also be because of refractive errors, age, and the patient accommodating. Now, in the market, we have a lot of commercially available aberrometers. And the question is, do we really need an aberrometer in our refractive practice? A few indications for aberrometry are to determine the source of aberrations. Is the cornea aberrating the image more, or is the internal optics aberrating the image more? Decision making in both refractive surgery and cataract surgery is greatly aided by aberrometry. Post-refractive surgery, unhappy patients, to assess why they're unhappy, where the distortion of the image is actually coming from, we need an aberrometer. Of course, for DLS and refractive lensectomy, accommodation and contrast sensitivity, it's also useful. Now, the first thing that I was taught in refractive surgery was that it's not the actual surgery that's the most important, but the decision making. The decision making helps your patient more than anything. So we come across these questions very commonly in our daily refractive practice. Do I do a corneal procedure? Do I put an ICL? Do I do LASIK? Do I do SMILE? For LASIK, do I do a topo-link LASIK or a wavefront guided LASIK? Do I do a wavefront optimized or a wavefront guided LASIK? Can I implant a premium IOL in this patient? Or in patients over 40 years of age, do I do a Pres-B LASIK or a refractive lens exchange? So aberrometry, let's see how it helps us with these decisions. Now the aberrometer that I'll be talking about is the Itrace, which is what we have in our practice. And this is called the wavefront verification display once you take a reading of a patient. So basically this measures 256 points. The principle behind Itrace is the ray tracing aberrometry, and it measures the reflected image from the retina. So 256 points that come through the pupil are measured and mapped here as a retinal spot diagram. So in a normal eye, it appears like this. In an irregular eye, you can see that the retinal spot diagram is quite distorted. It also gives you, it splits the total aberrations into lower order, higher order aberrations, and the HOAs, it further splits it into coma, spherical aberrations, and trefoil, etc. Okay. So this is a display called the Chang analysis. This is nothing but the RMS split into the total aberrations, the internal and the corneal aberrations. So the idea is that the cornea naturally has a bit of a positive spherical aberration of about 0.27, and the lens naturally has a negative spherical aberration, and these two cancel each other out. Now in this map you can see that even though the higher order aberrations in the total eye is a little less, the internal is a little more. So this may be cancelled out by the corneal aberration. So for such a patient who doesn't have very higher order aberrations, you can do SMILE. This patient is suitable for SMILE. LASIK itself may induce a little bit of spherical aberrations, whereas SMILE doesn't. Now speaking of SMILE, this is an example of a post-SMILE patient. Here, this is again another different display in Itrace. The central map that you see is a pre-op scan. The post-op 1 week scan. The scan on the left side is a post-op 1 month scan. So here you can see that there's something called tracy refraction. This actually gives you a sort of AR reading. So here you can see it's just plus 0.7 and minus 0.5. But post-op 1 month, you can see that the sphere is increased to minus 2. And this is nothing but on the right-hand side, this is a difference map. So in a post-SMILE unhappy patient, when we do an Itrace, we can see that there is accommodation. So this is a young patient who is accommodating after the myopic correction has been done by SMILE. So this particular patient had a history of stress, change of jobs, etc., and had a history, a stressful history. So he was accommodating, and post homatropin, etc., he did recover from this. So in this example, if you can see, this is the aberrations of the total eye. On the left side, we see internal aberrations, and below that, we see just the corneal aberrations. Here we can see that the internal aberrations actually contribute more so to the total aberrations, and there are hardly any corneal aberrations. Now, in such a patient, if we do a topo-link LASIK, then the patient will have a very poor optical quality post-operatively because he still has a lot of internal aberrations, and the corneal lower order aberrations may be corrected, but the higher order aberrations will still remain. So for this patient, we treat the eye as a whole. We treat the entire wavefront which is done by a wavefront guided LASIK rather than a TopoLink LASIK. Now, deciding between a wavefront guided or wavefront optimized LASIK. Basically, a wavefront optimized LASIK prevents the induction of new aberrations by giving extra spots peripherally and maintains the asphericity of the cornea. A wavefront guided LASIK, as we all know, corrects the pre-existing aberrations. So in this patient, if you can see, the total aberrations are around 12 micrometers, out of which the lower order total is almost 12.2 and 12.19. So there's not much of higher order aberrations. The Itrace also gives you potential visual complaints of the patient, such as night myopia, blurred vision, starburst, etc. So in this patient, we see that the higher order aberrations are not much, so we can go for a wavefront optimized rather than a wavefront guided treatment. Again, in this patient, we see the total RMS, and here we see high astigmatism and not much of higher order aberrations. It's mainly coming from the astigmatism is coming more so from the internal optics. So here we can actually do a just a wavefront optimized LASIK, since the higher order aberrations are not too much. Now, this is again a Chang analysis display. Here we can see on the left lower side that the corneal higher order aberrations are very high compared to the internal higher order aberrations. So in this patient, we can do a wavefront guided LASIK, but if the refraction is -6 or higher, there's a lot of tissue removal that happens. So this patient is a suitable candidate for ICL, just based on the Aborometry. Now, in patients above 40 years of age who come with diminished vision, these patients do have a chance of having an incipient cataract. So in such patients, we look at this display called the DLI, or dysfunctional lens index display. This tells you how much aberrations are coming only from the lens. So here we can see that it's below 5, it's 2.36. So in such patients, it's better to do a refractive lens exchange, because even after the Presby LASIK, they will still have these internal aberrations if it's done. So in presbyopic LASIK, there is a very important value called the Z4 value, or spherical aberrations. Basically, the idea is that we induce some spherical aberrations in presbyopic patients to improve depth of field. And these aberrations are kept between 0.35 to 0.56 micrometers. So there is a CRS master that we use, which has a Presbyon module, and this has a proprietary nomogram. We have to enter a Z4 value into that to get the customized ablation profile for the patient. And this basically preserves stereo acuity because it remains in that non-toxic zone of 0.35 to 0.56. Now, Aborometry can help us determine whether we can implant premium IOLs, because it gives you angle alpha and angle kappa. So angle alpha is the angle between the optical and visual axis, and it should be less than 0.5. Now let's look at this patient who's undergone a multifocal IOL. Here the angle alpha is 0.7, and here we see the total higher order aberrations are 0.36. This is the same patient in which we can see a high amount of coma. This is a borderline patient where the angle alpha is just 0.4, but still the patient is having high internal aberrations. This means that they're looking through the diffraction rings rather than the center of the lens. This is a multifocal patient with angle of alpha 0.1, and here you see that the higher order aberrations are minimal. So this is a happy patient post multifocal IOLs. So the take-home message, do we really need an aborometer? Coming back to that question. Yes, in our modern day refractive practice, we definitely, although we require other scans like our pentacam, our HD analyzer, etc., and it's something that we assess overall, Aborometry does point us in the direction of which decision to make regarding refractive patients. So basically, low higher order aberrations, patients may be suitable for SMILE or wavefront optimized LASIK. Significant higher order aberrations point us in the direction of wavefront guided LASIK if it's total, and if it's only corneal higher order aberrations, we can do a topo-linked LASIK. So significant higher order aberrations with a high refractive error, ICL may be more suitable. Also for patients over 40, always check the DLI, and before implanting premium IOLs, always check the angle alpha. Thank you very much for your patient listening.
Thank you, Dr. Supriya, for that excellent talk and showing those beautiful examples that nicely illustrated the use of Itrace technology and use of Aborometry, how these can be used for better decision making for refractive surgeons and how to create more happy patients. So, our last speaker, Dr. Sri Ganesh, does not need any introduction. Of course, we all know him as a very prolific cataract and refractive surgeon, a world-renowned surgeon who's contributed a lot to the field of refractive surgery. He has worked with probably every technology in refractive surgery, most of the excimer lasers. So we can't wait to hear his talk on ASOCT-based tomography system, which is the MS39 essentially, an all-in-one refractive workstation. Looking forward to your talk, sir.
Thank you, Sheetal. And good morning, everybody. I would like to thank Dr. Sheetal for including me in her IC, and we will be looking at the newer modality. Let me just get this up. No? Okay, that's okay, leave it. So we'll be looking at the AS-based tomography. So all of you all are very familiar with the Schleimflug-based tomography, which is the most popular being the pentacam. But the ASOCT has a few benefits over the Schleimflug. One is the resolution is much better, and some of the features. So I'll be talking about the MS39, which is a AS-based tomography system, which has it's the most advanced device for analysis of the anterior segment, and the MS39 combines placido-disc corneal topography with high-resolution OCT-based anter-segment tomography. It is the resolution of is about 3.8 microns of the OCT, so it's a very high-definition OCT. And it also delineates epithelium from the total cornea. You heard Dr. Sheetal speak on the importance of epithelium. So with this, we are able to get epithelial maps. And it also has a 16 into 16 millimeter diameter. So it includes the entire cornea, even larger corneas up till 12 millimeters. So you get a complete analysis. So let us look at some of the applications of the MS39. The most important for us as refractive surgeons is keratoconus screening, because you don't want to do refractive surgery on the wrong patient. This was a paper which looked at normative data and keratoconic eyes, and they concluded that the MS39 is a very valuable equipment for diagnosing keratoconic corneas with a high accuracy for many of the parameters. So if you look at the keratoconus screening, it has what is known as notable point spread. In her previous talk, Dr. Sheetal Mavakar said that you have to look at the thinnest point, the maximum curvature, etc., and then match it. But what the MS39 does is it has what is known as the notable point spread, and it has various indices. Normal is more than 1, 0.6 to 1 is borderline. Less than 0.5, you have suspicion of keratoconus. So if you look at the notable points, it has the epithelial thickness, it's got the stromal thickness, it's got the total thickness of the cornea, it's got the Kmax, anterior Kmax, posterior Kmax, and the elevations. And it looks at all these points and it gives you the slider scale, and here you can see it is abnormal. And you also have a yellow circle and a red circle. If all these points are within the red circle, then it is highly suspicious of keratoconus. It also gives you this red flag that it can be a keratoconic cornea, and you can see here it is 0.19, so it's highly significant. And then it also has the indices. Indices include the NPS, the curvature indices, elevation indices, corneal thickness, and the epithelial thickness. And all of them have a slider scale, and if it's abnormal, you get a red flag. It also gives you classification of the keratoconus. It gives you grading of the keratoconus, ABCD grading, and also the morphology of the keratoconus. So here it says nipple type of a central keratoconus. It also gives you other parameters like the keratoconus center and the axis, etc. It also has something special known as the Gaussian curvature maps, which are more sensitive and truly morphological, gives you a true morphology of the pathology. So the geometric mean of the maximum and minimum curvatures at one point on the surface are taken to get this map. And if you look at this keratoconus summary map here, you have the anterior surface, the posterior surface, epithelial thickness, stromal thickness, and corneal thickness. So you can look at all of them. And it also has the Gaussian anterior curvature, Gaussian posterior curvature, and the epithelial thickness pattern deviation. This is what I was talking about. So you can see whether it is, how different it is when compared to the normative data. And even stromal thickness pattern deviation and corneal thickness pattern deviation. And here you can see that the Gaussian anterior curvature again is different from the tangential curvature. So it's a little more sensitive. And it also gives you the corneal thickness progression. And then it also has classification, and it tells you whether it's a borderline cornea or a keratoconus cornea, taking all these into consideration. You can also look at keratoconus progression. If you have 2 or more maps, then you can look at the difference maps between the tests, and then you can also look at different indices. You can look at the anterior curvature, posterior curvature, anterior elevation, posterior elevation, corneal thickness, and look at the graph here whether there is an increase or a decrease. You can also look at the difference maps. Epithelial maps are very important. Dr. Sheetal has already dealt with it. I think Dan Reinstein and his group did a lot of work using the ultra high frequency ultrasound UBM to look at epithelial maps, but now the AIOC has a non-contact epithelial map with a very high resolution. The epithelium basically has a masking effect, so it thins out over hills like the center of a keratoconic cornea, and it thickens over valleys wherever there's a depression. And it has significant effect on corneal remodeling after refractive surgery. And with keratoconus, you can have what is known as the donut sign, where you have thinning of the epithelium in the center and thickening in the periphery, and you get epithelial maps with the MS39. So I'll go through some of the case scenarios. This was a 26-year female interested in refractive surgery. You can see that she's got a low myopia, 1.75 and 1.5. If you look at the pentacam, you can see that the bad as such, it shows that the patient has thin pachy of 458 microns, and like a form friste keratoconus picture on bad, you can see both the anterior and the posterior elevations are borderline, and if you look at the indices, they are all borderline or abnormal, and the total D also is kind of borderline. What happens is the pentacam gives more false positives for keratoconus, so it is the false positivity can be quite high, so it overdiagnoses keratoconus, and this is where we use the MS39 to look at whether this is actually a keratoconic eye or not. And if you look at this MS39, and all the indices, they are all normal except the thickness of the cornea, and the classification is normal. So you can see that the curvature maps, the elevation maps, the stromal elevation, corneal thickness is low, but all the other maps are normal. If you look at the epithelial map also, it's perfectly normal. It doesn't have the donut shape. So it classifies it as normal, and this is a thin cornea with a low power, so you can go ahead and do PRK safely in this eye. This is another case which is a 26-year-old male interested in refractive surgery. You can see again a low myopia with low astigmatism, and if you look at the pentacam, and it shows that he has a thick pachy, 561 microns, but the anterior elevation, posterior elevation on bad are abnormal. The total D, of course, is normal. So these are cases where which are perplexing. I mean, would you go ahead and do touch this patient, do a refractive surgery or not? And then we look at the MS39, and you can see that it's normal epithelial thickness pattern, normal classification. So the patient is suitable. You can, because it's a low myopia, you can either do PRK smile or even LASIK. And topo-guided treatment, cross-linking is not indicated. Of course, you can also use biomechanics, like Dr. Raghavendra said, to further confirm whether the cornea is normal. But the pentacam has a tendency to kind of overdiagnose keratoconus, and you will be rejecting a lot of your refractive patients. So this is something that you need to look at carefully. It also has advanced analysis of tear film, and this is a non-contact assessment, so you don't have to do your Schirmer test, or you can look at the non-invasive tear breakup time, and this is helpful for pre-op refractive evaluation. So you can see that it gives a tear film map. If it's green, it's kind of normal. It also looks at the first tear film breakup and then the average BOT. And this was an example of 25-year-old female with history of contact lens use for 5 years, and you can see that she has got minus 4.25 with one sill, other eye 4.75 with one sill. She wanted refractive surgery, but you look at the tear film. The tear film again shows that the first non-invasive T-butt breakup is at around 5 seconds, which is abnormal, but the average is around 10.3 there. So the first breakup is abnormal, and she has some amount of abnormality. So we stopped the contact lens, put her on lubricants, and manage the dry eye, and you can see how it improved. And you can see now that the tear film is much better, and the first breakup time and the average breakup time are almost at the same level, more than 10 seconds, which is normal. And the other interesting thing is, if you look at the K1, K2 values and her astigmatism, actually the astigmatism dropped from 1.5 to 1. So the tear film, when you have an abnormal tear film, it can induce some amount of cylinder and refractive error. So it's very important to treat dry eye before doing an assessment and taking up the patient. So that's how the MS39 helps in doing a non-invasive tear film assessment. It also gives optical quality analysis summary with the corneal wavefront, the point spread function, the visual simulation, and the MTF. So the corneal aberrations, you can look at it separately from the epithelial aberrations. So you can have a segregation, and you can just look at the, sometimes you can have epithelial aberrations which are more because of epithelial remodeling, and the cornea itself is normal. In such cases, you may want to modulate with medications like steroids for a longer period of time, and that's when it helps, where you can look at whether the aberrations are from the cornea, whether it needs further correction, topoling treatment, or whether it's just from the epithelium, because the epithelium is temporary. It also has pupillography, where which gives you the static and dynamic pupils. You can have the scotopic, mesopic, and photopic pupils. It gives you the measurements. It also gives you dynamic pupil center. So sometimes you can have a what is known as a centroid shift. As the pupil dilates, the center of the pupil shifts. This is important if you are using an eye tracker which centers on the pupil for doing your ablations, and you can study that with this. It also gives what is known as dynamic vault assessment. This was a paper which looked at the ICL and the changing vault on pupil size, and this is something which is significant. The pupil changes as the vault of the ICL changes as the pupil constricts or dilates, and you may want to study that, especially in cases where which have low vault, and on the pupil constricting, sometimes the vault can further reduce, and you can have a touch and a higher incidence of cataract. This is just a short video showing that. You can see that when the pupil dilates, the vault is higher, and as it constricts, you can see it constricts now, and then the vault reduces. And this is on scotopic pupil, it is 266, and on photopic it's 227. So almost more than 30 microns, 40 microns difference in the vault. It also has advanced lens biometry, what is known as ELED, expected lens equator distance and lens thickness, depending upon the size of the capsular bag and the lens thickness, and this gives you the predicted lens position. It has also ray tracing biometry, so it has the CSO software for ray tracing, and this is a patient who had undergone LASIK. She had a refractive error of -14, 1.5 cylinder, developed cataract. Now these are cases where you would want to be a little more accurate, so we do ray tracing along with the other biometry formulas like the Barrett TrueK and Barrett TrueK TK, and you need to put in the axial length in millimeters. You can measure it either with ultrasound or an optical biometer, then the target refraction, pupil diameter, and a constant of the lens to be implanted, and then it gives you the IOL power for you can see here it is 9 diopters, 10.5 diopters, and this is the residue. So this is also a useful tool in the MS39. It also has software for planning intrastromal corneal rings for keratoconus, and it has imaging, the AIOC2022, where you can look at the rings or even flaps, etc. So it's a high resolution OCT which you can use for all your corneal work. To conclude, the MS39 has multiple functions: keratoconus screening, selecting patients for refractive surgery, or choosing the best ICL surgery parameters. It also gives you lens size, which is important now for deciding ICL vault. Enables anterosegment surgeons to better understand the patient visual issues, choose the most appropriate course of action for them. Thank you very much for your attention.
Thank you, sir, for a very insightful talk on MS39. I think we have finished right on time, 10:25. Do we have any questions from the audience?
Sir, you said the pentacam tends to overestimate the keratoconus, but I think it is only limited with the smaller white to white. What are the other parameters? Because if suppose the patient's white to white is between 10.8 to 11.4, then I have seen that it tends to overestimate the keratoconus. But apart from them, is there any red flag sign would you like to say for the pentacam? Because majority of are having the pentacam.
Majority of you all have. There are also studies which have looked at the false positivity and specificity and sensitivity of the pentacam. So you can have a high overdiagnosis of, it's almost about the specificity is about 67% or something like that. So sensitivity is about, if it says it is normal, that means it is very unlikely that it is an abnormal cornea. But if it says that it may be a keratoconus cornea, there is almost 33% chance that it can be normal. And this is not only for small corneas, we see it on average corneal diameter. So this is something that you have to take care of. The other thing is you also have to look at the angle kappa, because sometimes when you have a large angle kappa, then you can have skew, you can have inferior steepening and in a normal cornea. So these are some of the fallacies of the pentacam that you should be aware when you are interpreting the scans, and don't take it on face value. The badly, this is what because we looked at the other scans also, and sometimes like I showed in the examples, it can be normal. So you may kind of be sending patients away whom you can treat.
So I think you need to have the AIOC2022 now in your practice.
AIOC2022 based, or you should at least, like I said, reevaluate and look at it and see whether it's actual keratoconus or whether it is the error of the software, especially for the bad screening.
See, having AIOC2022 for all of us is next to impossible. So that's not the way to go about it. If you have any doubt, and one parameter in pentacam is never to go by, but you can always repeat the topography and see whether it is consistent. If it is consistent over a period of time and there are no changes, you can safely go ahead with surgeries. And if you want to be still on a safer side, obviously surface ablation is the answer.
The pentacam became popular because of posterior elevation. Because what happens is keratoconus actually does not start on the posterior surface of the cornea. It starts on the anterior. The changes are first in the Bowman's layer. But what happens is, because of epithelial masking, you can't see the changes. Because in the topography, in most of the Placido-based topographies, it's basically measuring the tear film. And with that, because you have epithelial masking, it looks normal. So you take up and then you have ectasia. But even if the anterior surface is normal, because of the epithelial masking, the changes in the posterior surface are picked up by the pentacam. That's why the pentacam became popular. But then it has its other issues.
Yeah,
So
like the curvature maps of pentacam, they are like mathematically driven, so they are
Yeah.
not really very good, unlike your Cirrus or this thing. Cirrus is placido based.
That's
The
why they
curvature
included
maps of
the
Cirrus are
placido.
better. Yeah.
because the
So
curvature maps, the sagittal maps which you get are kind of
Yeah,
derived
mathematically
derived
derived.
from the elevation maps.
Elevation maps.
We see so many times discrepancy between cases. Pentacam most of the time shows yellows and reds, and then because the thing is that we are so used to seeing pentacam and those displays that we cannot think out of that. But so now that we have started using MS39 and also correlating the scans of both, so we have more confidence now in MS39, and once we see that the class, it's giving a normal classification, then we can decide with better confidence.
I think
Also,
there
to
is
be
one
very-
of CSO which shows the epithelial thickness, elevation, as well as the stromal one.
Yes.
I think it is a very useful tool. It will also
because
help you to.
It shows the
determine.
stromal
Yes,
elevation
exactly.
after subtracting the epithelium.
You can just
So
get the
it's-
epithelial maps. You can also get the aberrations from the epithelial maps, whether they are significant or not. So that
In fact, as a cornea surgeon, to be very frank, I really don't get into the bad D too much. I like those 4 maps, and they are really
Correct.
good maps
You
for you
just
to study.
have a,
Yeah.
a square,
No,
and
in
if you see
general,
that.
study all those 4 maps properly.
Thank you, sir.
Thank you.
So, any more questions? I think we will have to conclude the session. I just request Dr. Ganesh to just have a final word. This session was about how to become successful refractive surgeons. So of course, we've seen all the technologies that can help you become a better surgeon. But do we really need all these machines, sir? Because I'm sure a lot of our attendees do not have access to MS39 or even Corvis. So you have been in practice since 20 years, I think 2 decades of refractive
Yes,
surgery.
yes. I started off with RK.
So what are the
even
pearls?
before we had topographers. So, I mean, then placido discs were being used. So, there are, see, you can, even with your retinoscope is a beautiful abrometer. Okay, the CPU is up here, and that's the tool. You can look at spherical aberration, you can pick up spherical aberration, you can look at coma, early keratoconus, you dilate the pupil, do a retinoscopy, you can pick up early keratoconus. It's as sensitive if you are good at doing retinoscopy as your pentacam. So, clinically you have to be good. There is no exception to that. These are all tools of the trade. Okay, tools which help you refine your trade, but you cannot blindly go by them. Your clinical foundation has to be solid. Your clinical assessment has to be very good. And then these are tools to assist you in your trade, which is doing refractive surgery. So this is a toolkit for refractive surgery. You should be aware of what are all the technologies which are available, how you can use it, what are the positive aspects, what are the negative aspects. So as a clinician, you can kind of assess and know, okay, these are the tools available. When am I going to use this tool? When am I going to use this tool? And which is useful for what? And that's why this course has been designed, so that as refractive surgeons, you are aware of all this. And many times with aborometry, you cannot pick up scatter. You have patients with 6x vision, very unhappy. They may have microfolds, microstray. You can't pick that up with an aborometer. It will show you normal aberrations. Or you have a mild PRK haze. Patient has 6x vision, but his quality of vision is poor. He keeps complaining. That you can pick up only with a HD analyzer with scatter. So you need that. But if you do not have that, okay, you can just dilate the pupil, take retroillumination photographs, and then you can see that on your slit lamp. So it's clinical basis. The foundation is very important. But then these are tools which you can do. You are a busy refractive surgeon, you can't always do that. So these are tools where you get the screening and you have the reports, and at one glance you can see whether the patient is suitable or not.
Thank you, sir. I think these are the biggest take-home messages that we can take from this session. On behalf of all the speakers, I would like to thank all of you for joining us for this session and making this session very active and lively with your interactions. And I hope to see you all next year. Please provide a positive feedback about our course if you really like it. Thank you so much.
Thank you.